Good morning, everyone. I am Dr. Fazil on behalf of JIIU Indian Institute of Medical Science and Research. Welcome you all to one-day CME of challenges in renal diseases, kidney diseases, and its management. I would like to call Dr. Mohammad Shafi sir for recitation of curriculum.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر صدق الله العظيم.
Thank you, sir. So we start our first session. I would request Dr. Purushottam Giri sir, Professor at Head PHM Department, to kindly chair the session, and Dr. Dilip Bhave sir, Professor at Head Department of Biochemistry, chair the session. I call upon Dr. Mohammad Shafi sir. He is Professor at PHM Department at IIMSR. Dr. Mohammad Shafi sir is author in 45 publications He has a YouTube channel of awareness by the name of Muhammad Shafi. He is director of Elite CME Academy and have experience of conducting and organizing more than 100 CMEs. I request her to kindly take the mic for his talk on epidemiology of end-stage renal diseases.
Good morning, everyone. We'll start the CME with first session on epidemiology. So before we proceed, I would like to clear the term epidemiology because we most of the time use it, but many of us don't have real concept. What does epidemiology mean actually? So in medicine, epidemiology is used for studying any disease, but we need to see the various aspects of the disease. In epidemiology, we see the distribution of the disease and determinants of the disease. So mostly when we talk about epidemiology, it is about the distribution of the disease, and clinicians they know that when you examine the patient, first you see whether the patient is oriented in time, place, and person. So that time, place, and person is used to study the distribution of disease in epidemiology. So epidemiology of chronic kidney disease. Today I'm going to talk. I am going to touch very few aspects of CKD because the nephrologists are available here and they will talk you in detail about the disease and its management. So we'll just go through the epidemiology in terms of distribution and the determinants which causes the disease. And why we study all this? Because we want to prevent and control the disease. So community medicine is responsible for studying epidemiology of all the diseases, and it is their responsibility to go for control and prevention of the disease. So let's start the CME with the topic of epidemiology of CKD. So we'll just go through the distribution and what are the various determinants which will determine the occurrence of the chronic kidney disease. So CKD has emerged as one of the most prominent causes of death and suffering in the 21st century. So if you go back to 20th century, we hardly heard. Even I was working in one of the cardiology hospital in Nagpur, hospital 25 years back. Dr. Bahukar was the cardiologist with DM cardiology, and I worked with him. So that time we used to hear about acute renal failure and chronic renal failure. That time no terminology like CKD was there. But from the beginning of 21st century, there is a rising trend of chronic kidney disease. And this is partly due to risk factors like obesity and diabetes. It is said that by 2040, India will be the capital of diabetes in the world. And we are second largest country in the world, having highest number of cases, second to China. Then increasing number of CKD patients, estimated to be 843 million people are living with CKD in the world. Global burden of disease studies have shown that CKD has emerged as the leading cause of death worldwide. So we will see what was the rank before 25 years for the cause of the death by CKD, and now what is the level of the cause by CKD. So CKD should be identified, monitored, and treated. It is very important that you should first screen. And most of the diabetologists, nephrologists, they are screening their patients for presence of kidney involvement, particularly diabetic nephropathy. Preventive and therapeutic measures addressing CKD should be systematically implemented worldwide. Now coming to the definition of chronic kidney disease. So chronic renal failure or chronic kidney disease is a progressive reduction of functioning of renal tissue. So there is loss of renal tissue, because of that there is reduction in the functioning, and it is said that it is irreversible. It is irreversible. You cannot revert it. That's why renal transplant is becoming more and more common. So remaining kidney mass can no longer maintain the body's internal environment. So there are various definitions used for evaluating the patients of chronic kidney disease. Mostly it is the eGFR, that is glomerular filtration rate, is considered. eGFR from filtration markers such as serum creatinine or 16C using various formulas, or testing urine for presence of albumin or protein. So most studies they use eGFR for defining the staging of chronic kidney disease. Other studies they consider albuminuria also, and there are some studies which are using chronicity criteria in duration level. You have to test the patient over a period of time, and then you define or decide that the patient is having chronic kidney disease. So low eGFR or elevated urine albumin should be detected for at least 90 days. So chronicity criterion says that you need to follow patient at least for 90 days to label him suffering from chronic kidney disease. So it requires presence of repeated management over the time. Now, coming to the prevalence of CKD, it varies considerably from 8,327 cases per 100,000 population. So this is depending on various types of definitions being used to assess the prevalence of chronic kidney disease. So when it is used as eGFR, it is 8,327 cases per 100,000, and when you use time limited repeated eGFR based, then it is around 4,627 cases per 1,000 population. So I have gone through some of the meta-analysis done by various authors, in that they have seen that various authors they have used various types of definitions for defining CKD. So if you consider ICD-10, International Classification of Diseases by WHO, the prevalence comes to 775 cases per 100,000 population. So various definitions they consider various types of parameters for diagnosing and defining chronic kidney disease. This picture shows that there are 5 stages of chronic kidney disease, starting from stage 1 to stage 5, and stage 5 is usually called as end stage chronic kidney disease. And you can see here that in stage 4 and 5, 53% of the cases are detected, whereas in stage 1 and 2 and 3, 80 to 90% of the patients they go undetected. So stage 4 and 5 more usually we come to the diagnosis. In this stage, we diagnose the cases of chronic kidney disease. Now, when we should go for screening of chronic kidney disease, these are some of the related factors: family history of CKD, history of acute kidney injury, patients suffering from diabetes, hypertension, cardiovascular disease, age more than 60 years, and certain ethnic or racial studies for the US population. So, etiology of chronic kidney disease, the social economic consequences of CKD are considerable. In most countries, estimates of the prevalence of CKD stage 3 to 5 is eGFR less than 60 ml per minute, or around 5 to 7%. So 5 to 7% of the patients will suffer from CKD, mostly affecting people aged 65 years and above. The prevalence of CKD in hypertension, diabetes, and vascular disease is substantially higher. So these are the 3 determining factors which will determine the occurrence of CKD, diabetes, hypertension, and vascular diseases. So targeted screening for CKD should be considered in these and other high-risk groups. The great majority of patients with earlier CKD, stage 1 to 3, never develop ESRD, which is very fortunate. Now coming to the global prevalence of chronic kidney disease, it is said that people who are more than 65 years of age, 1 in 5 men are having chronic kidney disease, whereas it is 1 in 4 women. So globally, it is more common in females. There is one global kidney health atlas. They have published in 2003 that around 850 million people are affected by chronic kidney disease worldwide. And every age and race are affected, and people from this disadvantaged population are higher risk of getting chronic kidney disease. So here you can see 1 in 5 men and 1 in 4 women they have the chronic kidney disease. If the age advances, the chances of getting chronic kidney disease increases. Now this picture shows global chronic kidney disease market expected to account for $20.96 billion by. So chronic kidney disease not only have social impact but also the economic impact, and lot of cost is incurred on management of chronic kidney disease. So as the time will increase, the cost for management of chronic kidney disease will also increase. Now this picture shows prevalence rates for chronic kidney disease in selected countries worldwide. So these are the number of cases per 100,000 population. So you can see here, India also have around 9,525 cases per 100,000 population, whereas developed world also having more cases in the world. The economic cost of chronic kidney disease, the cost of treating CKD represents enormous burden on healthcare system worldwide. In developed countries, kidney failure is a major cost driver for patients, their families, and governments. But in developed countries, we know that the health insurance is available. So because of that, the cost on the patient is less compared to the cost in India. But now in India also people are going for health insurance, and that will cover the cost of treatment of chronic kidney disease. According to research report published by NHS Kidney Care in England, CKD costs more than breast, lung, colon, and skin cancer. So you can see that the cost incurred is more than these common cancers also. Then, according to United States renal data system, based on entire United States population, Medicare spending of patients, Medicare and Medicare, these are the two insurance companies in US. They spend money on treatment of the patients. So they say that around Medicare spending of patients with CKD exceeded 85 billion in 2020 and which accounted for 23% of the total Medicare insurance expenditure. In medical income countries, access to life-saving therapies has progressively increased, yet renal replacement therapy remains unaffordable for a vast majority of the patients. Yesterday, one of the sister of my friend got renal transplant in Mumbai. So most people who are belonging to high social class, they are able to afford the renal transplantation. Developing countries cannot afford dialysis or transplants at all, resulting in the deaths of over 1 million people annually from untreated kidney failure. Our hospital also is providing dialysis to the patients free of charge. Then CKD is common among US adults also. More than 1 in 7 US adults, about 35.5 million people, or 14% are estimated to have CKD. As many as 9 in 10 adults with CKD do not know they have it. So we need to plan screening among these people. And about 1 in 3 adults with severe CKD do not know they have the CKD. Now this is the results by the meta-analysis being done by one of the authors, prevalence of CKD in general population of adults in South Asia. So here they have given for India, Bangladesh, Pakistan, Nepal. So they have mentioned that the prevalence of CKD in India is around 2 per 1,000 population. Then prevalence of CKD in overweight and obese. So if the patient is obese and having diabetes, then chances of CKD will be more. So again, they have pulled the data and they have analyzed that the prevalence is around 1.5 for CKD. So chronic disease, kidney disease is rising in prevalence. Now, CKD is increasing at an alarming rate. CKD deaths increasing by 41% from 1990 to 2020, rising from the 17th leading cause. It was 17th leading cause. Now it has come to 10th leading cause of death by CKD. And by 2040, it is expected that it will increase, the chance of death will increase by fifth. It will be the fifth leading cause of death by CKD. So this is primarily due to changes in way we eat, drink, junk food, and move. So eating and drinking and physical activity. These are directly related with the chances of the chronic kidney disease. So I say that particularly metabolic syndrome, which is more related with the sedentary lifestyle and overeating or eating the foods which are very high in carbohydrates. Diabetes and hypertension are the key risk factors for CKD. Then most of the increase is occurring in low and middle income countries and among more marginalized communities. Middle social classes, they are suffering from more. CKD can occur at any age, but becomes more common with increasing age. I have shown you before, starting from the 60 years old age. Now coming to the prevalence of CKD in India, there is one study, SEEK study. They have done study in various cohorts from various parts of the country, and they have found that 70.2% of the patients are suffering from CKD with mean eGFR of 84.27 plus minus 76.46 versus 116 plus minus 44.65 ml per minute. So prevalence of CKD stage 1, 2, 3 and 4 was 7%, 4.3%, 4.3%, 0.8% and 0.1% respectively. So and as the age stage goes up, the prevalence is less. This is another, we have the CKD registry of India, and they have registered the cases in their registry, and they have registered 63,538 cases in their registry system, and mean age of male is 50.7 years and female is 48.1 years. Now this Indian map shows you the areas where we find more number of cases. So it is the Central Asia and Central India and South India where more number of cases of CKD are found. This is another according to the zones: East zone, North zone, South zone, and West zone. So stage 5 here is more in all the cases from various zones of India. Now coming to the risk factors which are determining CKD occurrence in India. So patients with CKD with older age, mostly males, more likely to have high school diploma, means they are educated, and more likely to be urban compared to the rural, less likely to have low income, middle income people, more likely to be overweight or obese, to have diabetes, hypertension, cardiovascular disease, than patients with or without CKD. So all those who are having these factors, they are likely to have more chance of development of CKD, odds of development of CKD will be higher among these people who are having all these characteristics. The most common risk factor is hypertension in 64% of the cases, anemia 40%, and diabetes 21% of the cases. Only 7.9% of the subjects with CKD were aware that they have CKD. So they have done study on regarding the awareness about the CKD among the patients. So many of the patients, almost 50% of the patients, they don't know that they are having CKD. Now CKD prevalence increases with the age. So as the age advances above 60 years of age, the chances of CKD will be very high. Now there is one publication, chronic kidney disease market in 2023, which has the current update regarding the chronic kidney disease. Then some of the symptoms I would like to highlight here. The symptoms of chronic kidney disease: dry and itchy skin, tiredness or weakness, puffy or foamy pee, swelling of hands, feet and ankles, puffy eyes, trouble sleep, loss of appetite, muscle cramps, need to pee more often. So they need to go to washroom. I have a short video on CKD. this video is published by NCD Alliance. Now, how we can prevent chronic disease? So, CKD is a silent killer, but it can usually be prevented. There are several ways to reduce the risk of developing chronic kidney disease. You need to be very active, eat healthy. So, these are applied for all. We all should follow that minimum 30 minutes of physical activity daily and small frequent meals. As we are having living sedentary lifestyle, we need to avoid carbohydrates and take more proteins and with some fat. Reduce your salt intake, don't smoke, check and control your blood pressure and blood pressure is part of your regular checkups. Usually after 30 years of age, blood sugar and blood pressure should be checked regularly. Get your kidney function checked if you have one or more of the high risk factors, diabetes, hypertension, obesity, and family history of CKD. So lastly, CKD is a progressive condition that affects more than 10% of the general population worldwide. CKD is more prevalent in older individuals, racial minorities, and in people experiencing diabetes, mellitus, and hypertension. CKD represents a large burden in low and middle income countries, which are least equipped to deal with its consequences. CKD has emerged as one of the leading causes of mortality worldwide, and it is one of the small number of non-communicable diseases that have shown an increase in associated deaths over the past 2 decades. The high number of affected individuals and the significant adverse impact of CKD should be prompt enhanced efforts for better prevention and treatment. These are the references. And thank you very much. I request all of you please subscribe my YouTube channel, which is my name, Dr. Shafi. So thank you. If you have any questions, you can ask.
Thank you, Dr. Sir. We are explaining in a very useful manner epidemiology. Because epidemiology is a very continuous determinants. And again, issue. We have focused on the prevalence of the CKD, which is more and one of the leading cause of mortality worldwide. If you see the prevalence, we are about 17.2% India. That's high. Even the worldwide, there are 850 billion people are affected by the CKD every year. And the last is the same 1.5. This 5 is the end stage of the disease. That is also what we will around 5 to 6% of the total world. So, thank you very much.
I request share.
Thank you, sir. Very interesting epidemiology and prevalence. And it is a very much high role of preventive medicine. Because the diabetes is increasing leaps and bounds, and that is why the risk of CKD is also.
One question, sir. Yes. You said you had a YouTube channel. So what program of kidney CKD awareness you conduct or do you conduct or not?
No, sir. Actually, we more focus on diabetes, hypertension, and other diseases like tuberculosis.
This is nice lecture, very nice lecture.
This is first time that we are having this CME on kidney. So it is live broadcast on our channel.
I request chairperson to kindly finish take our speaker. Thank you very much. Our next speaker is the founder director and faculty at Scholarland. He is president of SFM Marathwada. A huge work in urogenital, neck, and pediatric ultrasound. He is author of 2 chapters in textbook of radiology and have 23 publications in his name. He is a reviewer at British Journal of Radiology. He is a renowned national and international speaker. I call upon Dr. Anirudh Kulkarni for this talk on imaging USG, CT, MRI, and IGU nuclear scan in kidney diseases.
Thank you for the kind words. I think to overcome radiography to visual imaging is a very big task. I said, next 25 minutes. I personally believe the attention span nowadays is never more than 20 minutes. And I will try to put it the things in the right perspective in next 20 minutes. So, no financial disclosures, thank you for my entire entity who really provided me the information last 3 days or so. When it does and of course, because of whom we have done so many things, particularly further into so, looking at the imaging reports, most of the times we find looking at the report, you will always say that you are not able to understand what is given in the report or exactly what for which you have asked the report that is not mentioned in the report. So, usually there is a quite a bit of fighting between the person who has asked the imaging or on many occasions we will refer to higher imaging modality or the imaging findings usually given in the report will be equivocal. I mean, ये भी है, वो भी है, ये भी नहीं हो सकता. That kind of report. So what is that you should ask for specific things on ultrasound or CT or MR, and imaging investigations need to be done by the imaging guy in a based and structured manner, so that the kind of information that you have is really there in the report. So that's the way. So you look at this CT/IIU image and you realize that there is a huge hydronephrosis on the left side. You can see a tumor over there in the bladder, which is compressing the lower member of the regulator, causing proximal hydronephrosis. So entire imaging information which is asked in this question is really delivered to us. So you have a radiography, you have ultrasound, color Doppler, elastography, contrast ultrasound, regarding which I will be giving little bit details. You have CT, nowadays very popular with contrast and the high MDCTs. MRI information, few slides, and that's the Dr. Sharat together, and we will scan again. We will mention one or two indications and few images, and I am not expert on both of these. We used to advise give the ultrasound for years together for demonstrating the calculus vision. In this question, you can see calculus sitting opposite transverse process of L5 on the left side, and there is no additional calculus quality over there. But nowadays, it is being more or less replaced by non-contrast CT because you get so much of additional information on contrast CT that it cannot be replaced by JIIU. I give you again calculus disease along with malformation or post-operative patient is more or less only indication taken with IIMSR because it is being replaced by CT/IIMSR. But RGU and NCUG are still the main choice of investigations evaluating anterior posterior, particularly in case of reflex pediatric. So indications of IIMSR as on date, calculus and calculus along with anomalies could be one of the things. Now here you can appreciate the increasing cadence net program secondary to calculus in the pelvic course of research. Here you can see there is a congenital mega aggregator, there is a moderate hydrolytic emphasis on the right side, and here you can appreciate that there is a hydrolytic emphasis of random out of PCSS. And here you can see there is a left-sided moderate hydrolytic emphasis on NCUG. That is why it is not dilated, so probably you are dealing with higher rates of reflux. And in this image, you can see that there is a Hutch diverticulum which is involving the lateral wall of the bladder on the left side. It can be nicely seen on even ultrasound and even venous epigraphy shows a similar kind of picture, showing involvement of lower part of the bladder along with the lateral wall involving lower part of the bladder. Now coming up to ultrasound, ultrasound is comprising of terrestrial ultrasound, color Doppler, and pulsar Doppler, contrast enhancing ultrasound. One of the additional usage of ultrasound is guided techniques. It can be of a diagnostic significance like renal biopsies, prostatic biopsy, urinary drainage, or even cases of PCM where it can be used for therapeutic purpose. Now, ultrasound usually starts antenatally. We will start looking at the renal pelvis. We comment about pituitary bladder and we do not comment about urethra because that is against the PCP law. So in case of pediatric AFU, we look for hydronephrosis and renal parenchyma. We start commenting upon the hydronephrosis which was seen in terms of renal epiphyseal diameter, which is increasing or reducing. In case of adult, the commonest indication probably are medical renal disease, calculus, sepsis, along with calculus because of diabetes or tumors. Pre-transplant assessment of the donors as well as recipients post-transplant assessment, particularly looking at the different complications possibly associated with transplant or follow-up of graft regularly for renal vasculature or any abnormality in terms of resistance reduction eventually with a follow-up more than 5 years. Dialysis access fistula pre and post transplant assessment is a common thing that we need to do. Now, in terms of defining or asking the imaging investigation, we must demand that each and every ultrasound report that reaches to us mentions renal sizes, the cortical ecotexture and grading of medical disease, grades of hydronephrosis as grade 1, grade 2, grade 3, grade 4, depending upon involvement of lysis, renal pelvis or hydroregulator, mean cortical thickness in all cases of hydronephrosis because mean cortical thickness will define the kind of intervention probably is required. In case of urinary bladder, pre-void, post-void, bladder wall thickness, prostate assessment, and different areas of prostate for that matter. So, whenever it is reaching to us from nephrologist or urologist, we need to give attention to from renal sizes to post-void on the prostate. So, all the investigations we should not mention only the KU, but we also should mention regarding liver, bilateral pleural vessels, and some other because isolated KU ultrasound is absolutely a useless investigation for that. So good high-end ultrasound system is not a fancy tool. It is mandatory in each and every that it's mandatory in teaching institutes. Please do not request for shortcut tailor investigation like just look for prostatic volume, just look for prostate volume, just look for only hydronephrosis because we are likely to make more mistakes because we are likely to miss more or less other areas which are of equal significance. And do not entertain non-structured reports. I mean, WNL, no abnormality detected, abdomen is normal. This kind of reports should not be entertained at all unless and until all the findings pertaining to whatever our area of investigations are completely reached. So let us take example from here. You can appreciate that the tool is well preserved. You can measure the renal length, you can measure the renal weight, you can see the hilum very well. You can track down that hilum into the aorta for renal vascular rate, and you can see the color flow reaching up to the capsular surface of the kidney. So looking at the grayscale ultrasound, looking at the color Doppler, we can say that probably we are looking at a normal kidney on the right side, which is having normal cortex, renal length, width, PC system is not dilated, and the renal vasculature is absolutely normal. Now, in cases of renal hypertension, we have asked for renal artery stenosis, let's say region of the renal artery on both the sides. Nowadays, with the kind of equipment that we have, it's very easy to demonstrate the renal origins very easily. At the same time, we need to look for other vessels adjoining the renal artery like celiac gland and suprarenal artery because whenever there is some form of pathology involved in the artery, it is likely to be also associated with the involvement of suprarenal artery or celiac gland. And here you can see we take a section of long axis, short axis, we look for both renal artery origin. We compare the renal sizes and cortical electricity on right side and left side, and it is mentioned in the report pertaining to what is the size of the right kidney, left kidney, and comparative statement of the injection. In terms of grades of medical illness, this is the kind of report that we get every now and then, starting from grade 0 to grade 3. Whereas in case of grade 1, the size of the kidney is normal, the cortical electricity is raised, at the same time it is less than it may be more than or equal to spleen, or in association with the renal cortical electricity is very high and the thickness of renal cortex is less than 6 mm. At the same time, there is a poor distribution between the cortex and the medulla. So, usually in various shades in the renal brighter zone, that is how we can remember. So, ranging from a hypoechoic area which is say black in color, will be replaced by white shining areas which are nothing but a hypoechoic grade 3 or 8 stage. This is what I meant. So in case of this is a normal kidney, the cortex is hypoechoic. This is grade 1 electricity, where the cortex and medulla is still intact. This is grade 3, grade 2, sorry, where the cortical medulla electricity is lost. And here you can see it's a small size disease along with some amount of calcification in contrast to a normal size kidney grade 2, and you can additionally see some amount of calculus in the kidney. So range is from grade 0, it's a hypoechoic kidney, to a grade 3, it's a small size hyperechoic kidney, it can to hyperechoic or calcium kidney. At the same time, this is the reason why I say only kidney ultrasound is not selection. You can see that in all 8 stages of disease, you will find that there is a hepatomegaly, there is a hepatic condition. You can see that the IVC might be redirected. Along with that, you can see that along with IVC direction, you can see there is a mild to moderate kind of fasciitis which you see in the epigastrial space. And along with that, it will be seen in the characteristics as well as the clearly. So no investigation is complete unless until you take a complete survey of the remaining. Nephrocalcinosis is very common to occur. There you can see that the renal parenchyma is being replaced by hyperechoic enhancing areas on ultrasound with few calcific densities which are seen on either side. In addition to that, I can see that there is a large renal calculus within the renal pelvis showing strong echo over there. So nephrocalcinosis is a common entity is to do this. So whenever we say it's a late-stage renal disease or late-stage medical disease, it's a renal cortical thickness is less than 6 millimeter. It's more reliable when we say it's a renal size is less than 7. Renal length is reduced, increased cortical luminosity. There is a poor visibility of renal pyramids and renal sinuses. At the same time, there is irregularity of cortex. On many instances, we will get capillary calcifications. On many instances, we will also get a multiple kinesis involving the cortical region. The reduced vascularity is a common feature of occur, and the resistive index will go on increasing. So, what is meant by resistive index? Because that's what we usually get in entire more or less of different of the reports. It means the peak systolic velocity and end-diastolic velocity. So, peak systolic velocity minus end-diastolic velocity divided by the peak systolic velocity is resistive index. More or less, it ranges between 0.47 to 0.70, and difference between the two degrees could be 5 to 8%. Now, we know that in case of sepsis, there will be increased flow, and in case of medical disease, for that matter, the resistive index will go on increasing. So, in cases of a medical disease, we will find that the RI indexes are very, very high, and the cortical force will be very low. At the same time, in cases of where whenever we are evaluating the renal hypertension, resistive index will be abnormal. There you can appreciate the renal size is pretty small, and here you can see at the origin of renal artery, the peak systolic velocity are close to 60 centimeters per second, which means that we are dealing with renal stenosis or renal artery stenosis. On visually, you can appreciate that there is a mass over here involving the upper wall of the right kidney. As soon as I put the color Doppler, I can realize that there are multiple branching vascularities which are involving the mass for that matter. So, in fact, on biopsy, it comes out here, and angiomyolipoma liposarcoma. So, it was a rare kind of tumor and not classical RCC. So, contrast ultrasound is nowadays gaining quite a popularity, particularly in case of late-stage renal disease, or because it doesn't have any, you can say, any effect of the compromised arteries which we traditionally use for contrast. That is not there with ultrasound. Here we can appreciate that the remaining portion of the kidney is well contrast enhanced. Ultrasound contrast and not the usual contrast, and there you can see that there is an involvement of the area which is an abnormal area, which was an infected area involving the upper pole. Now, when you appreciate there is a hyperechoic globular mass involving the lower pole of the kidney, which is classical renal angiomyolipoma. So, bilateral renal angiomyolipoma, the next level of suspicion has to be tuberous stenosis, because you might get severe angiolipoma in case of the particularly ovarian into the female or maybe into some male. In case of a transplant kidney, the first thing that we need to assess is the vasculature where the anastomosis has been done. So, we look for the iliac vessel to the renal artery anastomosis and the iliac vein to the renal vein assessment. So, we look at the origin of the vessels, and then we go on looking at the entire vasculature from the renal pelvis going up to the periphery, reaching up to the capsular surface. So, we take resistive index involving the interlobar vessels, segmental vessels, renal artery, and level pelvis, three segment, and the anastomosis, so that we get an exact picture. So, this is the image I have taken from World Wide Web Internet, where you can see that there is a small athletic area. On contrast ultrasound, you can realize that it's nothing but a small athletic area of the farm. But as the remaining parenchyma was absolutely normal, no active intervention was required. Now, we can do renal biopsy very well by using the ultrasound. So, we need to target the lower bone. And if you do ultrasound guided, it's quite easy because you have a control. You do not have a much control as far as the renal movements are concerned, because in spite of giving good instructions, also there is likely to be some kind of breathing movement, because of which lower bone may have some kind of mobility. So, better to have a control over the native, and by the way of vision, you can exactly look at the part where I am going to put the native. At the same time, the churn that we get is usually always from the cortex, and no contamination from the peripheral system or other area is involved. So, it's very easy to do it on some guided way, and usually the tissue is very, very high. The renal cyst is again a common thing to occur whenever we get a report of renal cyst. We should always ask for what is the maximum size on that size, on right side or left side, or whether there is additional features of hemorrhage or sepsis involving that cyst. So just isolated cyst report should not be accepted. Just give to the mention whether additionally sudden increase in the size as compared to previous ultrasound is mentioned or not. Number two, whether there is hemorrhage or sepsis involving that cyst is mentioned or not. And again, we have a standard protocol of dealing with this disease. It will be adult in nature or it will be infantile in nature. And there is a various range of grading as far as mentioned. The same. So whenever we are dealing with multi-cystic disease, always also mention whether the pancreas and the liver they are also showing cystic disease or not. At the same time, if the patient is young, or you should need to follow the family trend as well. The kids as well as the parents to look for whether presence or absence of the cystic disease is present in the family or not. Now, small amount of periodic collections post biopsy are quite known. It could be infected or non-infected, or many instances post PCR or some kind of inflammation involving the kidneys can be seen. So, this kind of collections adjoining to the periodic space, if they are large in size, collection which is more than the PCG for that matter involving the overall, you can simply put the needle in the retrograde fashion and drain the same. And on many instances, if there is a huge heteronephrosis which has leaked outside the system, or in this patient you can see the kidney is absolutely normal, but there is a huge perinephric collection on the right side. On coronal that you can see it was acting like a page kidney, because of which there was acute episode of renal hypertension in this patient. And then you can see the dynamic ultrasound guided PCR in this individual, not a PCR, perinephric variance for that matter from on the right side. And eventually we could break the cost which was closer to 310 million individual, and the patient really responded very well on the later period of time. Coming to the MKCT, MKCT is a we can say multi-slice CT for neurodevelopment attack. It's a very key investigation. Commonest indication is the calculus disease. We can demonstrate the size, number, shape of calculus along with the acute densities, and we get to know that what kind of density it is happening, and what is the closest anatomical landmark to a calculus over there. Along with that, if there is an anomaly involving the upper system or the ureter, also can be demonstrated in human with the non-contrastivity. Angiograms definitely are very useful, particularly in case of pre-transplant graft areas. And CT-IIMSR for that matter gives so much of additional information apart from calculus itself. It is a mandatory knowledge. So the structural protocol of this reporting is mandatory in all cases of CT-IIMSR. You should ask for size of calculus in two dimensions, size of calculus, actual density, and presence or absence of obstructive cavity secondary to the calculus. What are the indications of CT-IIMSR? Hematuria, urothelial masses, calculus disease along with obstructive cavity, presence of ureteric picture, particularly post-interventions. Now this is how the CT-IIMSR is. So here you can see there is a classical stack on calculus. So not only that, you can get an idea of what is the inferior edge of that calculus in relation to the transverse forces of L2 on the left side. And not only that, you can rotate the image and see what is happening in and around that image posteriorly involving the lower limb. I think we know that the usually the PCR is the nephroscope is passed to 11 and 12 because of which we should know what is the distance between the calculus and the 11 and 12, which can be nicely seen in subsidiary. And here you can see in this, there is a small calculus over there, and not only that, you can see there is a calculus lower down here also in the lower one. So with the non-contrast CT on coronal plate, you get entire kidney starting from upper pole of kidney to the bladder and to the entire course of ureter. If it is distended, again the feature of anatomical locations can be defined very well. But if it is not under nephrotic kidney, a closest approximately area of anatomical location needs to be mentioned along with the side of the kidney. And here you can see that there is a left hydronephrotic kidney and there is a UPG obstruction. At the same time, you can see the right kidney appears to be absolutely normal inside. And here, right kidney is not directed. I can demonstrate the ureter intermittently throughout its course, left hydronephrotic kidney over there. And the moment I speak you completely, you can see that there is a left kidney obstruction along with the hugely hydronephrotic kidney on the left side. Here again, hugely hydronephrotic kidney on the left side. You can see UPG obstruction over there. I can see the contrast in the bladder, and the right ureter appears to be absolutely non-directed. So as I do complete survey, you can see that on the left side there is huge hydronephrosis with a pretty huge obstruction. So reconstruction images that we get out of MDCT are always more clinically relevant and important from the treating perspective. And here you can appreciate that the ureter entire exposed that is absolutely normal. I can say from upper calyx to lower calyx along with the normal anatomical community examine to that. So reconstruction images should be asked in each and every question where you are with this. And this is classically how you can demonstrate even so that the patient also will appreciate the kind of investigation that you are doing. So coming to renal angios, nowadays the renal angio has almost completely substitutes as far as diagnostic modality for renal hypertension is concerned. Where on the right side you can see the single artery, on the left side you can see two renal arteries, out of which the upper one is supplying almost 2/3 of the portion, the lower one is supplying the lower 1/3, and which also can be reconstructed like the renal normal substance. This lesion, there you can see that there is a complete cutoff in the middle zone, which is a classical feature of renal hypertension in this lesion. If you compare the renal length of right to left, you can appreciate the renal length on the right side is less. And then you can reconstruct those images so that a person who is treating the case is very easy for him or her to understand where exactly is the obstruction, what would be the common part of obstruction, along with comment about the aorta for its wall, its atherosclerotic flux, as well as the diaphragm and the supraventricular artery, which are the closer arteries to the artery, which also be mentioned. As far as MRI, so my sincere gratitude to Dr. Kondekar for these two slides. Indications of MRI more or less is for renal masses or all those regions probably there is a compromised case as far as KFT is concerned. So in those regions probably MRI and MRI can significantly show details of any masses. If they are present or in cases of CKD also. If the PCS and ureters they are dilated and the KFTs are dilated because of which we cannot do neither the IIMSR or CT again MRI with contrast will definitely give more information. And in those regions probably if you don't want to do MRI, so then fat surface image 3D MRI will definitely give an outline of this system in far more better. And there you can appreciate it is almost the way in which we are seeing the signal. Can you see this little 22 on both sides? These are absolutely normal between. This is a non-contrast 3D MR. So you can see normal between on both the sides, including the peripheral system, without giving any additional contrast. So if our patient is KFT compromised or has a CKD, but I want to have certain look about the peripheral system or renal contour or any size variation for that matter, probably 3D MR is the answer because we need not do any additional information that we want to know apart from what ultrasound delivers. So 3D MR is probably the answer. Just to mention anything about the scan again, this information is taken from Dr. Joshi. Is very kind of giving a lot of feedbacks on the researches. It usually gives information regarding renal tubular function and perfusion. Very useful in case of hypertension, renal artery stenosis, urinary obstruction, and very quite useful in case of pediatric patients also. So you have a perfusion phase, you have a parenchymal phase, and then you have delayed parenchymal phase and a post-wide phase, which delineate exactly the excretion from both the kidneys as well as comparative statements to each other, and we can get exact idea of amount of function that kidney are doing. So what's the JIIMSR scan? So we give a typically 99 m DMSA, which is nucleic acid for that matter, and we have a gamma camera. The indications for DMSA scan more or less are infections, ectopia, horseshoe kidneys, acute renal failure, or multicystic renal kidneys. And here you have a different group. The group A where there is no obvious renal scarring. On as we advances, there is an extreme severe renal scarring involved in that kidneys. Again, this investigation is very useful in patients where you have a antenatal hydronephrosis and radiculopathy, and eventually because of repeated UTIs postnatally in early phase of pediatric age group, they landed into the category of renal scarring if it is reaching the upper point. So crux is that as far as advice are concerned, we must always follow a protocol. What are the which investigation needs to be advised for that matter. There are many investigations which have got advantage and should be considered on priority. If there is a moderately heterogeneous process, on right side is created completely and we go for MCUG rather than going for IBD. We must demand good ultrasound and structural reporting. That is very important because ultrasound probably is the first line of immediate investigation which is asked in case of say calculus disease or non-calculus medical disease. And a good first ultrasound where the diagnosis is made is eventually very important in due course of time because that's a comparative statement for each and every ultrasound which is done in future course as far as that patient life is concerned. High-end equipment is not a fancy tool. I think the kind of units probably you have enjoyed as far as ultrasound is concerned. Good terrestrial ultrasound, good color Doppler, good contrast enhancement if you are doing contrast ultrasound. And even the higher end MDCTs like where you get images where they can be structurally replicated or number two from clinical perspective or operative intervention perspective, they can be very easily correlated with the modality of choice for that one. So must follow the cases for eventual outcome because the way in which we follow the cases probably we learn more and more and that can be integrated eventually next batch of cases that will actually. So thank you very much. I hope I was helping this in and next meeting. Thank you once again. Thank you, Dr. Bharat sir, for giving me a time. Even though the topic was quite vague, I think I tried my level best to be precise and concise, but in the desired entity of India.
Thank you, Doctor. Nicely. Overall, radiology, including pictures
And I can see because it's a mixed crowd, not so very. If I would have spoken more on the text, probably nobody would have enjoyed. So I thought that let us make it more colorful in showing the other cases which can have a little bit of visual impact that can last in the
Nowadays, referring the patient to neurology center versus point of care services, say, all ICU, all dialysis units, all places where treatment is being done, is investigation should be available.
Perfect.
So the concept is learning to teach techniques which are available in medicine.
Perfect.
Therefore, point of care, ultrasound.
Focus. It's called the focus. Point of view.
Yes. So all physicians, all gynecologists, all surgeons should learn how what are different roles, what information they can give, what is the code for Doppler, what is the code for abdomen, so chest, lungs, all those things are really worth learning for each of us. And one of the purpose of giving this lecture was to say that it's not referring the patient and that's it. It's all you have to learn. Doing yourself on your own patient or point of care services.
But I think that training is equally important. I mean, it should not be a half-hearted one. And secondly, one should understand that the ultrasound per se has got its limitations. And need to understand. I mean, it is not going to be an overnight process for that. If I learn on Saturday, Sunday, looking at 50, rather than like from Monday onwards, probably I will be looking at all medical diseases. So it's a learning curve, and everybody should have inclination to that because finally it is just like a stethoscope. Because I know it's very easy to use in case of musculoskeletal system. It is very easy to use in case of anesthetics also for central lines because I on the operation side for central lines I use it. So, but learning is very important. One must learn and then try these methods rather than
Portable sonography nowadays.
whatever is see it's banned. It is institution. It's institution. Yes. It's see pocket head are banned in India. Other smaller gadgets they are easily available and they can be used in institutes. That cannot be used as from one center to another. It can be used within one premises. It cannot be used from say A to B. In A premises, it can be used from say 1 to 100, no problem. We cannot be shifted from one place to another.
Is there a study that if each and every dialysis changes in the renal or ultrasound? This we do the ultrasound, we keep on dialyzing the patient, and we do the ultrasound later on, after 2 months, 3 months, 6 months like that. But is there a study that yes, after dialysis, the ultrasound has been done, and there is some changes of like that? Is there a study?
Post dialysis.
Post dialysis.
Post dialysis, renal parenchyma is used.
Yes, yes.
No, absolutely there is no. Only thing is that what we usually look at is that whenever there is a renal transplant done and at that period of time the primary kidneys are of say X size. If the transplant graft over a period of say 15-20 years that fails, then later on the parent size then it will increase on size and you might see some amount of hyperviscid or what is some activity in the older dead ones. So that's the appreciated but not the dialysis.
Probably he's saying serial doctor studies.
Yes, doctor and put the ultrasound, put the ultrasound.
No, so
The doctor ultrasound, yes.
So sequentially seeing and studying the arterial flow
Changes
yes.
This study, is there any study like that?
Yeah, there are lot of these. Serial Dopplers on renal perfusion is one of the tests which we do in transplants. But
The transplant is participated. The CKD patient who is on dialysis, are there any changes shown after the dialysis? Before dialysis, after? Is there a study like that?
No.
It's not required. Basically,
It's not required.
what is the purpose of doing a test? So the machine is there, patient is there, doctor is there. What's your indicator? What's in your mind?
So just I want to see any changes.
I will at least identify the report.
Right?
One point I want to add. See, whenever we giving the reports, actually we should not suggest or advise the clinicians. Sometimes in institutes we suggest that I will be CT, I will. This is just suggestion of this because in one modality you cannot diagnose all the things. So that's why we advise further modalities. So just keep it in mind. That's it.
Okay. For our hospital or medical college, usually nephro radiology monthly meetings can help both of the students, medicine students, and they can learn from you, and your residents can learn from us.
Yeah, sure.
So,
Okay, we can go ahead.
It can be
our radiology.
basically it has to be nephro, uro and that's a more useful for them.
Connecting with pathology.
Yes, of course. Pathologist, without pathologist,
No, for patient and biopsy.
no, they are the only one who cannot say that please correlate clinically. I mean, they always say histopathology is the final diagnosis.
Thank you.
Not only that, sir, we are planning for recent updates in imaging from clinical indications perspective to 02. So this will help to all.
Yes.
So one day CME we are planning for.
Thank you.
Thank you.
Thank you everyone. I request the chairperson to kindly felicitate our speakers. Come on this side. Now you can take photograph.
Yes.
That is correct. I request chairpersons to kindly take their seats. Thank you very much. Dr. Sunil Kulkarni sir, what to say about him? Emeritus Professor of Nephrology at NGA Medical College. He has done his DM from Bombay Hospital and became the first nephrologist of Maharashtra. He has 40 years of faculty experience with 7 MD, 7 DM postgraduates or super specialty graduates under his guidance. He is founder member and ex-president of Zonal Transplant Coordination Committee, Aurangabad. He has participated in 24 organ cadaveric donation in Marathwada region. He is members of many societies, author of 35 research papers, and has a chapter in API Medicine Update 2017 on chronic kidney diseases of unknown etiology. I call upon him to give his talk on cadaver organ donation, a concept awareness. I request Dr. Yogesh Prakash sir and Dr. Madhur sir to kindly chair the session.
Thank you for kind introduction. I thank this institution, JIIU, and the auditors specifically for calling me for the topic. The previous two lectures, I would like to put some background for my lecture. First was about epidemiology. So the ticket is going to increase. So next by 40, it will be almost double. So I want I encourage them to be a nephrologist rather than doing cardiology. So I'm doing marketing of my branch. Those who are MD, at least they can have training in nephrologist analysis. So I think doing sonologist by a physician, doing sonologist by a radiologist, Dr. Manikar, it is a safe difference doing dialysis by nephrologists, doing dialysis by physicians. So finally, radiologist is the third number. He is already told he will be the final justice. We can do bedside, but there are some limitations for bedside. The first lecture, epidemiology, was figures and figures and figures. It is very difficult to remember. The only thing you can remember is that kidney disease is very important, non-communicable disease. Now the focus is on more non-communicable diseases. Because the mortality because of cholera, typhoid, malaria is still there. But now the non-communicable diseases are becoming more important. WHO also has started survey. Even Government of India has started survey of important 10 communicable diseases. And now this year, kidney disease is also included. You know that kidney disease is increasing, and there is great need and great demand for serving these people. There is a great financial burden on society and healthcare. We are spending so much money on dialysis. And finally, what the patient lives for 4 years, 5 years, maximum 10 years, and they are not physically active. They have no output. So we are just keeping them alive. So ideally, they should go undergo transplant. It's not only for kidney; it is for heart, liver disease. Then we have to do corneal transplant or blindness. So there is a great need of organs, and organ donation is very important. In PSN, there are two terms. There one is felt need, and is unfelt need. Felt need is food, water, something, pani, and Jalna. So organ is not a felt need unless you have some family member suffering from kidney disease. Somebody needs kidney, heart, liver. Then you think this organ is really important. But if you see the society, it's very important. I will just tell a story. This is Mr. Scarpa. I don't know what is the cost of Bentley in dollars. It is the costliest car available. We have BMW and whatnot, but this is a Bentley, is an international brand. So he once decided to bury his Bentley, and he publicized in paper, "I am going to bury my Bentley." So people were asking, "Is he fool? He should sell that, donate the money to society, do something charitable work." And really, he had a made a arrangement for burial. All paper people and everybody audience came, and they were asking, "What you are doing? But do you think I am a fool to bury my Bentley car? Have you thought of what is the cost of your body, organs? You can imagine that when somebody has calculated, if somebody lives and dies for 10 years, the cost is about 1 crore. So one kidney approximately 1 crore. Then one heart, one liver, eyes, you cannot calculate. So you are burying so many valuable organs, and you are worried I'm burying my car. So this was just a drama to give a message. Anybody from students, what do you see in this slide?
How it works.
Hmm?
How it works.
You know, probably. So usual answer is black dot. So about organ donation, there are more black dots known. Kidney चोरी हो गया, doctor sell the kidneys, patient sell the kidneys. These are more printed media than what is done positively. So concentrate on white background, the black dot. So the figures change, 7%, 10%, or at least 1 in 10 Indians have a kidney disease. We are not talking about CKD, GM are less than 60. So the definition is being wide, is whatever it is. So having one kidney stone is also CKD. Having just albuminuria is CKD. Having hematuria is CKD. So you calculate like that. Any structural, functional, or metabolism abnormal in a kidney is CKD. That is the definition. So patient has no symptoms of only structural is a grade 1. That is also CKD. So project SRD, as I said, it was 7.60 million in 2020. So are we really bothered? This question should come in mind. Are we really bothered? 18 people died daily due to unavailability of organs in India. Worldwide, we don't know, maybe some thousands. There are 5 lakh deaths every year due to lack of available organs. The rate of organ donation rate in India is dismal 0.8 per million population. The highest is in Spain, Sweden, Ukraine. It is 35, 25. Here I will just give what is this, why the donation rate is more. There are 2 schemes. One is out and off scheme. Our scheme is off scheme. I have already given some forms and that. You must have gone through it. So if you want to donate, you say I am opting. If you don't want to donate organs, say I don't want to donate. Don't sign the card. Don't tell your family. Then I want to donate, I don't want to donate. So this is opt-in. There are some countries where out, you have to say that I do not want to donate. Otherwise, it is granted that your body belongs to nation. And that's why Spain, Ukraine, they have many high incidence of organ donation. So why this is important? Why this topic is very important? Because the poor people are exploited. So Chennai was a black spot in India, where most of the unrelated, unregulated transfers were done. There was one Jhoppadpatti, where every male person had one kidney. They are survey carried out in the Jhoppadpatti. So every male had one kidney. They have sold kidneys. Dr. Nagesh and myself were working in Congress in 1993 till this go came. So all those people of Andhra Pradesh, Kerala, they didn't know Marathi. They were brought by aeroplane. Kidney was transplanted and they sent home, or what happened to donors, we don't know. So this was the reason. There was an article in Lancet in 1991, kidney on sale in India. And that opened the eyes of Indian women. And there were a lot of discussion in Lok Sabha. And finally, 93, 94, the so Act was passed that unrelated transplant has to be monitored. So voluntary health association in India estimates that about 2,000 Indians sell kidney every year. Still, in spite of Act, the kidney sale is still will work. The WHO estimated in 2007 that organs trafficking accounts for 5 to 10% of kidney transplants performed annually across the globe. And that in India, around 2,000 Indians sell kidney every year. This is a bad state of affairs. Across Nepal border, people are flown to Sri Lanka, Singapore, they carry tourist visa and they are transplanted. So why such malpractice? Large demand and less. Does that happen? So need of the hour. In India there are 3.7 lakhs organs are available. 1.5 lakh cadaver. 50,000 heart, 1 lakh liver, 1 lakh cardiac. Figures speak themselves and you can tell. But the patients who are waiting only 3.25 receive the organ transplants. Organ donation needs to increase. And these were out of 3.25, 80% are living related. So they are out of emotional attachment, mothers, fathers, wives. And unrelated transfers or cadaver transfers are 20%. Unrelated, there has been very few because of this act. So what can be donated before death? You can donate blood. This is very common. Kidney, one kidney, because we have two kidneys. Part of the liver can be taken because the rest liver regenerates. And now they are taking a part of pancreas. So liver pancreas for a diabetic nephropathy can be done even from the living donor. What is this cadaver donor? Cadaver is not a dead body, but we dissect the anatomy. So there are two types of death. One is somatic death, cardiac death, which happens at home, or it can happen in hospital. So it is cardiac death. The heart has stopped, and what we accept conventionally as death, there you can take eyes and skin. If there is death at home, we can take eyes and skin. Skin is still not popular because we don't have skin bag. It is available only in Mumbai. If the death occurs in hospital, we can take eyes, skin, and bones. The bones can be taken, but they are replaced with probably bamboo, so the body doesn't get disfigured. Now even the hands, the traumatized patient, hands are transplanted. One Jawan who lost two hands in the war had transplant and is back to his work. The brain death has to be in hospital. Brain death is certified only in hospital by a recognized brain death committee, which is recognized by the government of Maharashtra. 5 people certify brain death. That is the brain stem death. Patient is not breathing. His heart is working, kidneys are working, liver is working. Respiration has stopped. He was ventilated. We can keep patient on ventilator for 7 days, 10 days. You know, one of the cricketer was alive for 1 year on ventilator. But probably will not brain dead. He will not survive for 1 year. So that is possible to keep patient on ventilator for very long time. So if he is a brain dead, there are some brain dead tests that I will not do in the details. How to declare brain stem death. Because it is certified brain stem, and then we retrieve the organs after the consent of relatives. Why I am giving this card is you fill this card and give to the family. If you wish to donate, you tell your family that I want to donate the organs. Because if a transplant coordinator, so doctors ask after death whether you want to donate organs. You should not be surprised. What is this nonsense? My patient has died and you are asking for organs. So anybody who is in the card, if you don't want to donate, just don't discuss, don't give the card. If you want to donate, keep this card with you. Tell your family, wife or father that I have a wish to donate my organs. So brain death, we can get kidney, liver, heart, lung, intestine, pancreas. One person saves 8 lives. And multiple tissues, nerves, skin, tendons, muscles, anything can be used. So it is called, our body is like narrow tree. Every part of narrow is used, is spoken. Every part of narrow is used. Similarly, our body, everything is used. So whole body can be decided. This imagination, at present it is 0.8 per million. In case it increases 3, how many organs will be there? It is 10, how many organs are there? It is 20. We can get 22,000 organs, 44,000 kidneys, 22,000 hearts, 22,000 livers, and 22,400 eyes per annum. Sri Lanka highest rate of cornea retrieval. They are exporting cornea because their population is less and donation rate is very high. They are exporting. We import cornea from Sri Lanka. So how many cadavers? USA 52, then Europe 27, predominantly cadavers, and in Asia predominantly living cadavers. Our program, cadaver program is not very active. So top 10 countries by transplant will be maximum transplant. US maximum, India is second. In between China, because China's numbers are not authentic. They are taking organs from those who are executed. Prisoners are taken for execution, immediately their organs are transplanted. So they don't publish, but this is already documented. The rate of cadaver transplant in China is very high, but there is no documentation because of illegal things. Then comes Brazil, Iran, Mexico, Pakistan, Japan, Saudi Arabia, Turkey, South Korea. We are doing well. That way we are the highest number of transplants next to USA. So the credit goes to nephrologist like Bhavik Paragon, who started transplant in Aurangabad. How many you have done? 2,000, 3,000? He's not counting now. He has stopped counting. So credit goes to Indian enterprises, just like Nagapur. So we should be proud that we are doing a lot of transplants, but the need is still very high.
1248.
So that's why I was saying now we reach to learn. Now these students should again invest. So this is state-wise. We are doing well. Maharashtra is doing well. First is Telangana, next is Tamil Nadu. We are fourth or fifth. But India is going for more organ donations. That's a foundation like Home Foundation. National foundation like ROTO. ROTO is National Transplant Tissue Organ Transplant Organization. That is covering whole India and what is going on in every state. ROTO is a governing body. And there are regional bodies like ZTCC. ZTCC is regional. Aurangabad, Pune, Nagpur. Aurangabad, Pune, Nagpur, and Mumbai was the first ZTCC. Ours was the last. Nobody was ready to work for ZTCC. I don't want to take credit, but they say you have to take responsibility. Other things don't happen. So one day I decided that we should have ZTCC. I just pursued the matter. Some person said, "अरे काय लष्कराच्या मागे करतो? तर काय होणार आहे? उगीच कटकट कशाला करतो? पेटीमध्ये पैसे तुझ्याकडे." But I think 2016 January, we were lucky to have first transplant. We first cadaver transplant. And from 16 to 22, now we have 34, 35. Farad 31. 35. 31. So we are going ahead. So there is hope. One person has donated 2 organs for a wife, for her husband. The Tila Donda Vasanari Ajit Savitri. So she gave kidney and then she gave part of liver. This is a very good message for us. New Delhi, 2 women, a Hindu and a Muslim, donated kidneys to each other's families. This was stop across. There is a brother mismatch. But this donor matches with this discipline and this donor matches with this discipline. It is crossed. Proving that religion doesn't matter when it comes to saving lives. We are there for saving lives. The religion doesn't come in way of saving lives. Even a 3-year-old Irish in his death saved 4 lives. 3-year-old child. The liver can regenerate. So if a child liver can be transplanted in an adult. Heart has been transplanted for same age because you can't have a small heart in a big person. 2 kidneys of a child can be transplanted to 1 person, 100. They will function for at least 1 kidney. So these are some good things. What is our experience? Last 7 years, 31 categories. 12 hearts retrieved and liver transplanted. 25 liver transplanted. Recently, 1 week back, we had liver transplant in India. All hospitals, including government medical college, participated in the program. Government medical college gave 2 cadavers. Nalanda Medical College gave 2. Nagpur Medical College gave 1. So I have a lot of expectations from this institute, which has very good personalities, my colleagues, my students, my friends. So I have come with expectations. Total transplant centers in our 12, 2 in Nanded. There is 1 NTORC. What is this NTORC? It is non-transplant organ treatment center. You don't do transplants. But even if you are ICU, you have rented person. Organs can be retrieved and taken to the hospitals which are doing transplants. So this institute can become NTORC. You can become a transplant center after 2 years, but at least start NTORC. So these are various organ and tissue which can be donated. Angadan Jarutman Ki Vardhan. So government is propagating the message. So now they want to introduce a chapter in school syllabus. It may start from 4th or 5th or 6th. At least you should know that there is something. A body can be donated for dissection, organs can be donated, eyes can be donated. So start from childhood. So this is donor card which I have already given to each of you. You have to fill your name, Gadu, and your signature. If you don't want to fill the card, don't fill it. And even if you fill the card, it's not compulsory. Because finally it is the consent of your relatives who will give the consent. You are given the consent, but they say, no, we don't want these organs to be taken. So don't be under impression that if you have signed the card, that means the organs will be taken. It's not like that. It is finally the relative signature consent which is important. This is my card and my wife's card. So action speaks louder than words. We have donated our organs to the society. So who can become an organ tissue donor? Anybody can be donor. We have seen 3 years child, brain dead. Adult it has to be more than 80 years. Living donor has to be more than 80 years. It can be up to 70, 90. Then it says liver can be taken even at 70. Heart can be taken at 50. Cornea can be taken even up to 100 years. So any part of our body can be used. Don't assume you are too old, too young, or not healthy enough. Who will decide whether the donor is healthy or not healthy? People have taken the death of COVID patients. The patients who died of COVID, they have taken their organs because we don't know whether COVID is there in kidney. So some COVID deaths, they have taken organs. People who cannot donate organs may still be able to donate tissues. We don't want to donate organs. But a part of skin which is taken from back, you can donate skin. Most religions support organ and tissue donation. Living donors can donate kidney or partially. So this was the activity to just promote organ in all religions. This was a good news. धर्मगुरु ने एक मंच पर अंगदान को बताया सर्वोच्च दान. अंगदान को लेकर बढ़ रही जागरूकता. So there is a Hindu guru, Christian and Muslim leaders. So now there is a lot of discussion. They are all coming on one dais and discussing. No religion stops organ donation. Giving somebody life is our job. There is a book. You can read it. All major religions support organ and tissue donations. And this is a specific book which is written by Muslim scholars and some more people. Organ donation and religious beliefs. A guide to organ and tissue donation and Muslim beliefs. You can go through it. It's very good. Probably that time it was thought that only heart can be given. तुम्हें और क्या बोले दिल के सिवा तो हमारी उम्र लग जाए. So you can donate दिल, you can donate kidney, you can donate pancreas, you can donate anything. And by donating, you become a hero. सितारों से ऊंचा हो बहुत बड़ा. बोलो तुम धनी जिंदगी का साथ. So donors are heroes. Real heroes are donors. If anyone saves a life, it is as if he saves the life of all humankind. Thus, many Muslims understand from this verse that donating one's organ is a blessed act. In 1995, the Muslim Law Sharia Council UK issued a fatwa, religious edict, saying organ donation is permitted. It is not compulsory. It is all voluntary. So there are some contraindications I will not discuss, like tuberculosis, HIV. So this is the government directive that you should display this in every hospital. Every hospital should declare brain death. Nobody declares brain death. Because in tedious, you have to have a brain stem committee. You have to do apnea test. Declaring brain death is a difficult job. But the government wants to declare brain death. Otherwise, patients are kept on ventilator for weeks together. And the hospitals are blamed. So I think there will be two benefits. One is getting organ, and second, wrong bad image of doctors that they keeping their body alive. But people are not willing, and even ladies are not willing. We need to have a brain death declared and withdrawing ventilators. It is only Kerala where it is legalized. Kerala, you can terminate ventilation if brain death is declared, whether it donates organs or doesn't donate organs. Other states, brain death is declared only for organ donation. But Kerala has given the decision that you can declare brain death, switch off ventilator. So conclusion, organ shortage is a crisis. If it is a crisis, organ shortage is a crisis, and there is a cure. In India, we need to network and start thinking, sharing resources, expertise in organs. Use media for promotion. Get religious heads to participate. Have transparency in organ allotment. There is always a doubt whether these cadavers we are working in the DCC. We have a transparent list which is available in every hospital can know who are the patients who are waiting, what is the first number, second number, third number. So whenever a cadaver comes, that hospital gets covered. They can give the people, they can give liver, they can give heart. And the second organ, second kidney goes to those who are on waiting list. And that list is known to everybody. Everybody knows my number is blood group is B, I am first in the blood group B. So if there is a cadaver named with blood group B, I should get it. So there cannot be any mischief or what you can say. We get a message, it's not possible. Even our chief minister had to go to Chennai to get a liver transplant. One of the ministers went to Chennai for heart transplant. So you cannot indulge or you cannot manage this, you cannot manage this. Last week there was an application given to government medical college Jalna. The number is not there. And my patient, you are still there. You were there. So my patient is suffering from kidney disease. Kindly arrange for 2 kidneys. So that letter came to us. Kindly arrange 2 kidneys. It's a name. You cannot arrange for kidneys. You be in the list wherever there is brain death. So your life depends on somebody's death. Somebody has to die of your blood group. So that kidney should come to this hospital and then you will the kidney. So you cannot apply for a kidney. So regional transplant coordination forums, these are very important. JIIU are working very hard. Social appreciation of donor family. We have to appreciate donors. They should be felicitated. So encourage people to discuss organ donation. We should discuss. When the wishes of the deceased are not known, only 50% of people will agree to organ retrieval from their relatives. See, he has not given the form, 50% will say, okay, take the organs. When you already given the consent, the family knows that he had a wish to donate organs, then the number may increase. More disfigurement of body. The incident is taken from sternum to previous superficies, heart is removed, pancreas, intestine. The lungs can be taken from thyroid organ. So body remains like that. There is no disfigurement. So there is nothing, no obstacle in rituals. Rituals are possible. Encouraging people to speak about organ donation and transplantation and to make their wishes known to their relatives will change the picture. We are getting 93 to 94% of people allowing donations. We want more people to allow donations. Initiation by eye and skin donation. Usually we talk about eyes first. Whenever there is a red day, we initially talk about the patient there. We want to donate eyes because eye donation is even common, just like blood. See, if somebody is willing for eye, then we ask for other organs. See, that we don't have that patient will get the gem. So, medicine is happening. So, this is a Vishwanathan. This is Vishwanathan way of asking organs. Just ask organ. If they say eyes, no, don't go ahead. That job is done by Mr. Farhan, which should face him after the lecture. He's a hospital coordinator, doing a very good job. Since he joined there, then 3. So initially with eyes and skin, consent for donation, giving donor card, the driving license. Some states have made a donor card on the driving license. So when you get a driving license, you know that say yes or no. Consent of his family following death. Some form of combination of the two are necessary. At the time of issuing driving license, filling form for other government schemes like Aadhaar card, so anything, the card should be made compulsory. Government help and determination is needed. NGOs or groups involved in organ donation in any part of the MP have tackled various issues. This is in some states. Issues in the field of cadaver organ donation and transplantation simultaneously. More support groups with common objectives are needed. More resources necessary to kickstart such an initiative like prospect labs. Problem is there is no financial support from government. We have ZPC. We are autonomous. We don't have funds. We have to create funds. Somebody donates, some companies donate, and we get some money out of organs. Suppose somebody gets kidney, we get 50,000. Somebody gets heart, we get 50,000. So like that, we collect money, but we have to spend on retrieval. If the retrieval bill is 1.5 lakhs, the disease has to pay that bill. So government has to give some finance to the ZTCCs or to whatever bodies are there. Otherwise, this program will not run. But still it's running. So what is my dream? Abdul Kalam has said, dream is not what you see in sleep. Dream is thing which does not let you sleep. So my dream is to get donor card free by every person in our life. So we started activities in JIIU. आपल्या आम्ही सगळ्या घेऊन जाऊन येणार पृथ्वीवर करत आहे पृथ्वीनंतर अवयदान करा. थँक्यू.
Excellent talk, sir. Basically, in Western countries, majority of transplants are cadaver transplants. The proportion in US is 70-30. 70% cadaver, 30% plant. In India, we have more than 95% living donors. The biggest challenge for kidney transplant is organ shortage. In India, 2 lakhs patients are on dialysis, and Moto has only 5,000 transplants per year. Last year, so far, 10,000. Probably we, nephrology community, is failing for educating our masses. There are so many deaths, said 22,000 organs for 10 donations per million. Some such data was available. So actually we should have full-time teachers educating masses and leaving apart our dialysis transplant programs. You or me or somebody who is fully in charge of educating masses only for cadaver transplant, then only probably it will help. So organ shortage, and that's why the concept of keeping this lecture today was in medical colleges. If we push this as a chapter and exam, if we ask each exam compulsorily for transplant, donation, concept, majority of doctors, cadaver transplant means they don't understand what is cadaver or disease, the donation after cardiac death. There are many things. So sir has presented excellently, and I think the purpose of today's awareness creation on this medical college. We have, I promise you, sir, so we will soon develop your first JIIU. Yeah, Dr. Nagapur and we will start like non-transplant organ transplant.
I think every civil hospital should also start this NTOC so that it can be really fast. We will get the organ.
Everybody has started in
Yes,
recently.
yes, yes.
The main purpose of JIIU is not getting organs.
Yes.
Education.
Education.
Farhan, can you just say 2 minutes, whatever you have done last? Come on. You should know who is the coordinator of Indian as well as the coordinator for JIIU. Whatever activity we conducted, we started this.
साइमल्टेनियसली 20 एक्टिविटी कंडक्ट किए थे औरंगाबाद में. कॉलेज, पब्लिक प्लेसेस, इवन कंपनी, MIDC, Chandra, 22, and 2023 we conduct 4 activities.
So we should felicitate Mr. Bharat. Transplant coordinator is the main body. Every hospital must have a trained transplant coordinator. There are courses, online courses or physical courses. Mandatory is to have a well-trained transplant coordinator. They are the key person. Doctors never go to the patient and say, "You want organs," because this patient is benefited. Transplant coordinator are going to get everything. He is a key person. So he is the best person to.
हमने ब्लड बैंक में भी काम किया था. एक स्टूडेंट कि दीजिए खून को अपने मौका किसी और के रगों में बहने का, ये लाजवाब तरीका है कहीं किस्मों में जिंदा रहने. आपके जैसे ऑर्डर का डोनेशन है, इसमें भी यही शेयर है कि अपन उसको अप्लाई कर सकते हैं कि भाई दीजिए मौका अपने जिस्म के हिस्सों का रिकॉर्ड करता.
जोर से बोलो ना.
एक मिनट. चलो बोलो.
दीजिए मौका अपने जिस्म के हिस्सों को किसी और के जिस्म में जिंदा रहने का, ये लाजवाब तरीका है कहीं जिस्मों में जिंदा रहने का. और अच्छा था हमने तो
आपको
So nice. Mukherjee sir and madam has been there for many of the ICU programs that we are conducting recently. Also, he was there in one of the functions, and they are coordinating intensive care workshops. And main part of this talk was that probably awareness has to be there more. Then only the cadaver organs will be donated, and organ retrieval centers, they are more important because say 10 organ retrieval centers can be there, and two transplant centers like they can get up the other organ retrieval centers. More important is like organ retrieval centers are more in need, and that we can project at many of the places. Now government is also projecting many medical colleges per district also. So each and every research center, medical college center can be a organ retrieval center for that. That's why that this was the most important talk in both CME. The awareness has to be there. And it is I think talking on that cadaver and that.
I would like to add to the discussion. I was waiting for all the seniors. What I have learned right now is I read a lot of books and a social activist, many religious books, but I have not gone through that organ donation book that you have mentioned. And we are a bit stigmatic or afraid of the point that should be discussed a lot. We stay in India, and India is very religious country. Okay, we all follow religions. We are very religious people, and that is one of the major hurdle in organ transplantation. And another one, what I have seen up till now, I am very young, but what I have observed is after the episode of Amir Khan in Satyamdev Jayate, doctors have lost their morality. Yes, that is a black dot in the mindset of the people. Now, even if we give a Dynapal injection to someone, so he says, "Ke doctor sahab injection ke paise bada." That is one of them. But people do listen to religious, leaders. And what idea came to my mind, and as my guru and all the seniors are here, Ganesh sir is my guru. So I would like to recommend that if we can arrange a conference only for the Muslim monarchs, if we can, and not a conference but a day workshop, and we will put all the hadiths, we will listen what they have to tell. I think Farhan bhai will be definitely a coordinator in that. We will call Dr. Faiz, Advocate Faiz Ahmed, and we can also call Dr. Shada Musa, and avoid doctors in that conference because people are not much listening to it. And you are the experienced owners. But this is the point that I think in this closed room we should talk very frankly about the stigmas that we are having. People are not listening. If you go to some family and ask for their organs, if their father or brother has died, so definitely they will accuse us for some misconduct for that. But if a religious Maulvi join us, being a Muslim, I'll talk about the Maulvi part of view, and if they join us and they are regularly with us, so I believe if team could be prepared. NGO Al-Farhan is working in medical, we can also talk to them. Al-Farhan is fair there. But we are talking about blood donation, but organ donation. So, despite of a doctor talking, I believe a Maulvi talking on this will be a better forum for masses to agree for acceptance for religion. And thank you very much, sir, for this. Thank you.
Index is the one between the building. Three organs are in so they are very important. Unless the cadaver is maintained properly, so electrolyte balance. So index is, I just forgot to mention. So everybody, there are 100 people working in that line. So we got their details. I think you should have only CME. When you are around there are 100 people. From airport to railway station to the green corridor, everybody is working there. Thank you.
It's a big one. This one that is mirror cell. Like this.
We could take a tea break. Okay, we'll take a tea break for 5 to 10 minutes and we'll continue with the session. Thank you very much.
तो ये टॉपिक को
क्या बोलता है?
मेरे को चार्ट ले ले, तू भी चाय ले लेना। चलिए चल।
पूर्व आकार देतो.
मूर्तुजा
हा पूर्व मूर्तिजा पूर्व आकार.
request all the delegates to kindly take their seats. I call upon Dr. Bhushan Bipole sir. He is Associate Professor in Department of Anatomy, has more than 3 research works going on currently. He is a member of Medical Education Unit. I hand over him to kindly speak on anatomy of kidney.
Thank you very much, Zubair sir. Good afternoon to all the respected teachers and my colleagues over here. Welcome for the CME. On behalf of JIIU's IIMSR Medical College and Research Center. Once again.
Sorry. I request Dr. Damli sir and sir to kindly share the session. Thank you, sir.
Now, everybody from us, we have gone in our curriculum at the time of first year, we have heard the lecture of the kidneys, anatomy of the kidneys. Just revising the same things. First of all, the introduction, kidneys are a pair of excretory organs which are situated on the posterior abdominal wall, one on each side of the vertebral column behind the peritoneum. That means they are retroperitoneal organs. Okay, kidneys are retroperitoneal organs. Now about the dimensions of the kidney, each kidney is bean shaped. Okay, it is having upper pole, lower pole, lateral border, medial border, anterior surface and posterior surface. About the location, it occupies partially epigastric, hypochondriac, lumbar and umbilical regions. Vertically, each kidney extends from the 12th thoracic vertebra up to the 3rd lumbar vertebra. Now, about the presenting parts, each kidney it shows upper pole, lower pole, lateral border, medial border, anterior surface and posterior surface. Lateral border is convex, medial border is concave, and it shows a depression called as the hilum. Now the relations at the hilum or the structures present at the hilum from anterior to posteriorly. Okay, it is the renal vein, renal artery, and renal pelvis which continues as the ureters. Now, each kidney it measures about the approximate weight is 150 grams in males and 135 grams in females. Now this diagram it shows the relations of the kidney. It is as I have told you earlier that it is anteriorly covered by the peritoneum. So that is the peritoneal relation. They are lying behind the peritoneum. Okay, now the anterior relations of right kidney and left kidney, they differ, okay, as you can see. But the posterior relations, I'm not going in detail, but the posterior relations, they are common. From right kidney and left kidney, in the upper part, they are related to the diaphragm, and the diaphragm is having medial arcuate ligament and lateral arcuate ligament. Now, in the lower part, they are related to three muscles: transversus abdominis, quadratus lumborum, and psoas major muscle. Also related to the subcostal nerve and subcostal vessels. Now, the coverings of the kidney. Now, inside outwards, it is covered by the first covering is the capsule, fibrous capsule of the kidney. After that, it is the perinephric fat or the perirenal fat. उसके बाद में आता है renal fascia, and after the renal fascia, it is the pararenal fat or the paranephric fat or pararenal fat. Now, renal fascia, somewhat not going in detail, but it is having different parts medially, how it merges with different layers of the abdomen. Now, commenting about the, we'll later on go for the coronal section of the kidney, but before that, some about the arterial supply of the kidney. And the as the arterial supply is segmental, it is having 5 segments. Each kidney is having 5 segments, and the arteries, renal arteries, they are the directly branches from the abdominal aorta, and they are supplying in a segmental pattern. First, they divide into anterior and posterior divisions. After that, they are called as segmental arteries. These segmental arteries again divide into interlobar arteries. Interlobar arteries again they form arcuate arteries, and in the end they form interlobular arteries, which are the head arteries. Now, this is the coronal section of the kidney, shows macroscopic structures. Okay, microscopically we will see later on what is the histology or microscopic structure of the kidney. But first of all, what we can see with the naked eye on the coronal section. Just we will wait for the diagram. Thank you very much. Now, as you can see, the coronal section of the kidney, this is the outer cortex, this is the medulla, and this is the renal pelvis. Now, the renal medulla, it shows approximately 10 conical masses. They are called as renal pyramids. It is having a apex and a base. Okay. Now, about the cortex, it is having a cortical cap or cortical arch, and the renal column which extends in between the two pyramids, renal pyramids. Now, the renal pelvis, it shows 2 to 3 major calyx, and each major calyx, it divides into 7 to 13 minor calyces, and each calyx or calyces, they are indented by 1, 2 or 3 renal pyramids above the apex. They drain into it. Now, each cortical arch with the renal pyramid, is called as lobe of the kidney. Is called as lobe of the kidney. Again, I will repeat, each cortical arch with the renal pyramid is called as lobe of the kidney. Next slide. Already we have seen the arterial supply of the kidney. Just in brief about the microscopic structure of the kidney. Just in brief about the now already we have seen the macroscopic structures, but some microscopic structure, that is the convoluted tubules, medullary rays. Now the functional unit of a kidney is the uriniferous tubule, which consists of nephron and the collecting duct. Cortical nephrons with renal corpuscle in the outer part of the cortex and short loop of MD in the medulla. Juxtamedullary nephrons with renal corpuscles is near the corticomedullary junction and now loop of Henle. Parts of the nephron. The nephron is an epithelial tubule consisting of the following parts: renal corpuscle, PCT, that is the proximal convoluted tubule, DCT, loop of Henle. Glomerulus, about the structure of the glomerulus. This is the Bowman's capsule surrounding the glomerulus. It shows simple squamous epithelium, visceral layer. So that was all for today, just in brief about the anatomy of the kidney. Thank you very much. Thank you.
Nicely, Louis.
Thank you very much.
to kindly facilitate our speaker, Bhushan sir. Now I call upon Dr. Mutala sir. He is sir has experience of general practice for 30 years. He has 10 publications in his name. He is an international Lions Club cabinet officer currently. He was Lions Club's president in 1670, president of IIMSR in 2011 and 12. I hand over the mic to sir for his talk on pathological investigations on kidneys. Thank you.
The topic is renal function test. It's a beginning actually of the kidney diseases, and where we can be alert enough that any abnormality in the simple tests like urine or very simple tests which are non-invasive, non-expensive, and these can direct you towards the many things that some abnormality is going on. The renal function tests are affected by many things. It may be pre-renal, renal, or post-renal, and find out the further investigations on the now in renal function test, the first test that we come across for the kidney disease is urine test. And probably this is the most important thing, that it is done of every patient, not taken seriously. So it should be done very seriously, and all physical, chemical, and microscopic examinations of the urine should be seen by the senior peoples, and any abnormality should be reported so that the further investigations can be taken. Now there are various tests which are designed to find out the functions of the kidneys, that is concentration and dilution test, and to find out the functional capacity. Then impaired renal functions, they results in elevation of end products of protein metabolisms, namely blood urea, blood nitrogen, and creatinine. A clearance test of all these to assess the rate at which glomerular filtration and renal blood flow takes place. These include clearance tests of the many substances like inulin, mannitol, creatinine, urea, and para-aminobutyric acid. Renal biopsy is performed to establish the specific diagnosis of renal diseases. It can be sonographic guarded, and can be taken very easily, the small pieces, which can give you the complete structural and functional picture of the kidneys. Now, why test renal function? So many diseases affect renal, and several functions are affected. In others, there is a selective impairment of the glomerular function of one or other tubular functions. Most types of renal diseases cause destruction of the complete nephron, and that is in the end stage. Examples of renal diseases can be there. We can start with the renal status of the kidneys. They are functioning properly or not, or maintaining homeostasis in the human body. Then, steps in urine formation. They are very important, and because of which we can plan the investigations. That is, first, the blood reaches the glomerulus. From there, it starts the glomerular filtration. Then, as parts of the nephron show that in the nephron, it is tubular reabsorption, tubular secretion in the terminal part. The rate of urinary secretion of any solute is rate of glomerular filtration plus rate of secretion and minus rate of reabsorption. So these are the 5 parts which have been shown. And this glomerular capsule, proximal glomerular tubules, distal glomerular tubules in the collecting duct, and then there is a excretion, is a phenomenon of urine formation. Now urine volume, simple things like polyuria. Polyuria is normal blood urea, nitrogen and creatinine. Oliguria, renal ischemia due to toxic agents, dehydration, or obstruction of some areas of the urinary tract. Cardiac insufficiency may lead to oliguria, and anuria, which is complete urinary tract obstruction, acute cortical necrosis, glomerulonephritis, and acute tubular necrosis. Now, the chemical tests are carried out to detect the presence of protein, glucose, red cells, and hemoglobin to assess the permeability of the glomerular membrane. A number of convenient diagnostic tests are available for testing these chemical substances and pH of the urine. These consist of paper strips impregnated with appropriate reagents and indicator sizes. The bacteriological examinations of the urine is done by proper and aseptic collection of the very strip specimen of the urine. Then urine analysis microscopic examination. Yes, it is on unstained sample. Various components are observed are red cells, pus cells, epithelial cells, crystals, and urinary casts. The casts are modified into cylindrical shapes by passages along the tubules in which they are formed, and they are the result of precipitation of albumin and also the tubular secretion of the tan or protein. This is the name of that protein, which is a high molecular weight glycoprotein normally secreted by ascending group of inlet, and this will contribute and probably has body defense function. Normally, its secretion is increased in glomerular and tubular diseases. Now, casts may be highly type consisting of only proteins indicating a non-inflammatory etiology, leukocytes cause, inflammatory in origin, or red cell cause, like in hematology. Now, concentration and dilution tests are by giving the fluids to the patient and finding out the concentration and dilution of the renal tubules. The ability of the nephron to concentrate or dilute urine is dependent upon both functional activity of the tubular cells and the presence of diuretic hormone EDA. Failure to achieve adequate urinary concentration can be due to either defects with the renal medulla or nephrogenic diabetes insipidus or due to lack of EDA. Now, concentration and dilution tests traditionally they can be judged by specific gravity of the urine. Its normally range is 1.003 to 1.030, average 1.018, which in cases of tubular diseases remains constant at approximately 1.10 regardless of changing levels of hydration. Determination of urinary specific gravity provides only a rough estimate of the osmolarity of the urine. The tubular disease can be diagnosed in early stages by water deprivation, that is concentration, or excess by dilution tests. Now, in concentration tests, an artificial fluid deprivation is induced in the patient for more than 20 hours. And if the nephron is normal, water is selectively reabsorbed, resulting in excretion of urine of high solute concentration. If the tubular cells are non-functional, the solute concentration of urine will remain constant regardless of stress of water deprivation. In dilution tests, an excess fluid is given to the patient. Normally, renal compensation should result in excretion of urine with high water content and lower fluid concentration, the specific gravity may be below 1.003 or less. Now, blood chemistry, impairment of renal function results in elevation of end products of protein metabolism. This includes increase in accumulation of certain substances in the blood, chiefly urea. Normal range of urea is 20 to 40 milligram per deciliter. Blood urea nitrogen and serum creatinine. Blood urea nitrogen is 6 to 1.2. And increase in the end products in this blood are called as ammonia. High levels of creatinine are associated with beta 2 microglobulin in the serum as well as urine. A low molecular red protein filtered excessively in the urine due to a glomerular disease or due to any increased production by the liver. Microalbuminuria is also the phenomenon by which, in the beginning, we can say that diseases like diabetes have started filtering the albumins, low molecular weight albumins. Now, serum creatinine, it's a breakdown product of the muscles and excreted by glomerular filtration rate and tubular secretion. It doubles with each 50% decrease in GFR. Now, if serum creatinine is 1 milligram per deciliter, it is 100% renal function. That means it is working. And if it becomes 2 milligram, then that means 50% of the renal function is deprived. So it's a clear-cut thing. Don't take it that way. That if it is 2 milligram, then it is 50% reduction in the renal function.
If there is a 3 milligram,
And
if there is a 3 milligram per deciliter,
it is you are proceeding towards chronic kidney disease.
if you 1 milligram into 100%,
Yes.
if you 2 milligram to 50%, you can 3 milligram to 25% or 0%.
Not like that. It's present in the muscles and it may be affected by diet, by various concentration and dilution of the human body. So whenever we are taking the normal persons and we are finding it out, the serum creatinine itself. So then you should think of it. And normally, now the figures are given per liter. That is 55 to.
If the creatinine start rising,
Yes, sir.
then 30% also start dropping. This is the golden rule. When the creatinine start rising, there is a kidney function drop by 30%. Even if it is single or it is double. Even if single kidney patient has a normal creatinine, but if it is a double function, if it is less than 30, it start rising. That is the golden rule.
So that's why serum creatinine should be taken with previously creatinine data role in the investigations is probably the only thing that we can say how much kidney is disease. Now, creatinine is the end product of creatinine metabolism. That creatinine, when muscle gets activated or locomotion, the creatinine present in the muscles gives ATP and this produces the end product creatinine, which is excreted by the kidneys because it is of no use to the human body and it is excreted. It is not reabsorbed. That's why the clearance can be used, urea clearance can be used as a specific test for the glomerular filtration. Now, 98% of the body creatinine is present in the muscles, where its function as store of high energy in the form of creatinine phosphates. About 1 to 2% of the total muscle creatinine or creatinine phosphate pool is converted daily to creatinine through the spontaneous non-enzymatic or loss of water or phosphates. And the figures of milligram per deciliter when multiplied by 88.4 or divided by 88.4, it gives the figures in the micromole per liter. Now, creatinine normal values are 0.5 gram per liter per hour during the excretion of the creatinine and varying according to the muscular weight. Now, serum creatinine, we have seen that it is 55 per 20 micromole per liter normal and reference values, and creatinine clearance is about 90 to 140 ml per minute in the males and 8 to 125 ml per minute in the females. Now, a raised serum creatinine is a good indicator of impaired renal function, but a normal serum creatinine does not necessarily indicate normal renal function. A serum creatinine may not be elevated until